with the mask because of COVID, then victory sign like a V, she will hold the finger. Patient has a reflex of not accepting your endoscopy. So she has to push the head more towards me, like a little flexion, not too much of flexion, like a he has to welcome the scope. He should not refuse the scope. This is the most important thing. She will restrain, she will assist if necessary, and they are going to record. So four staffs ideal, but you can manage with the two staffs. I'll tell you also that. Okay, let's go without talking too much. Let me just see this. You have a feel of what's seeing. Okay, and this is the monitor. Now I am going to talk. The language of the monitor is clock. I'll treat the monitor like a clock from henceforth. So 3, 6, 9, 12 o'clock. Okay. And when I place in the oral cavity, okay, patient sometimes they'll have a temptation to, so you should not see something like this. That is a teeth. You should not see any teeth ideally. So you make sure, you see the tongue, preferably the tongue is actually now you see it is more towards the 12 o'clock. What do you see? The soft, smooth, this is the soft palate, tongue above. Tongue above, soft palate below. I go just in between. This is a little trick. It will take some time, especially in anxious patient. Then you go to an area where you go to the post-cricoid region. Okay. Then I'll enter the esophagus. Okay, because I know this patient is very anxious. The sooner you get into the esophagus is better for everybody. Because the most difficult thing all of you soon learn is the intubation is the first hurdle. Second hurdle is going through the navigating into the stomach. Second hurdle. Third is jumping from the antrum to the pylorus through the pylorus hole. And the fourth hurdle is from D1 to D2. And the fifth hurdle is coming back, retroflexion, see not to miss anything. So these are all the things. So first hurdle we have quickly managed, but I'll tell you little tricks are there. Now esophagus is the easiest part. It is like a motorway. We are going, okay, and she has to help you, or you can see the marks are there in the endoscopy, 30 centimeter. Now it is roughly around 25 centimeter. The 25 centimeter is the place where you normally have some amount of extrinsic compression. 15, 25, 40, the numbers you know from your undergraduate time, isn't it? So 15 is a place where we enter the cricopharynx, which I didn't waste much time. Now 25, but 30 is more constant in my opinion. If you see on 30, at 12 o'clock, you can see pulsating left atrium. Can you see it now? You can even count the heart rate. Transesophageal echoes are done only by getting a probe somewhere here. So you go up to here. Then this is the transition zone, or what I call a Z line. That will be around 38 to 40 centimeter. Okay, 38 in his case. Okay. So just to go in here. Is little tight. I'll tell you why. Then we entered the stomach. Okay. And when you enter the stomach, what you observe here is not much fluid. There is a little bit of fluid there. That is usually what we have puddle of fluid. And if it is a lot of fluid, you aspirate. Otherwise, you have to now again see this area again into clock position. What do you see here? Around 9 o'clock is the anterior wall of the stomach. Okay. So if you see there in the monitor, if I press, okay, you can see the indentation. See, can you see? Feel? So somewhere. So this is anterior wall. Okay, like this. And here, more towards the 3 o'clock is posterior wall. That is the pancreas. You have to imagine pancreas. But more important thing is 6 o'clock and 12 o'clock. That is important because the 6 o'clock here is your greater curvature, and the lesser curvature is at 12 o'clock. You have to always feel as if you have to walk along the greater curvature. So I have to have the trajectory. I have to walk along this. Okay, if I keep going like this along the floor, it's floor of the swimming pool. If you imagine it is a swimming pool, you just walk along the swimming pool. Pylorus will be knocking at the door. You will go to the pylorus. If you have that motorway, it's like just to go in that lane, don't turn anywhere, you'll go there. So once and you bring the pylorus right at the center, then you will be easily entering into the duodenum. And go into the junction of the D1 and D2. There I will do some tricks. I'll tell you in the second case. Okay. Then that will take you to the second part. Then I'll shorten the scope. Okay. And as I pull the scope, actually I will be diving in. If you watch, I don't know how many of you appreciate it. See, when I pull, I'll be, but if I turn my body like this, I'll be actually falling back. So this is called paradoxically we'll be doing. In other words, you'll you'll see something opposite to what you are trying to do here. Okay, let's we'll quickly see here because he had already a fund duplication. Okay, I'll tell you, and that's why when you went in, the OG junction was lit. அமைதியா இருப்பாங்களா அமைதியா இருக்கணும் நான் தான் சத்தம் போடணும் நீ சத்தம் போடக்கூடாது பேசிட்டு இருக்கேன் அமைதியா ஓகே so you can see here about 2.5 centimeter wrap is there and this is not a normal configuration. So the wrap is tight. You can see the scope is tightly gripped by the newly created the valve. Okay, 360-degree Nissan's wrap is working, is actually too tight, little bit tight because he's had a foreign body sensation. So I wanted to see exactly what is the reason. So we need to decide whether he needs dilatation, but all I can say is I have done what I call a J manual. Okay, and I'm able to see. Then the last thing I'll do is I'll deflate because the reason why he was shouting maybe because the stomach was too distended. So always you have to be very, very watchful. You want a distended stomach, but not a ballooned stomach. So I'm just sucking. When I suck, see what happens? Immediately the stomach comes back to normality. Now I am insufflating now. You can see again at distance, all the brugal pores will start disappearing. And when I suck, it will reappear. So this is called a distensibility test. The property of the stomach is distensibility. If that property goes, one of the indirect evidence of linitis plastica. Because sometimes the mucosa may look normal for a beginner, you don't know. So this is the one important test you need to do. And the last, we always empty, keep the area empty and keep coming back. See, you can see, this is the area. I went with a little difficulty. See, it is not normally welcoming. It looked like a pseudo-achalasia. Pseudo-achalasia is a failure to relax. Why it was not relaxing? Because we are wrapped it. But it is okay. It is acceptable. I don't think. There is a little bit of blood-stained fluid. Don't worry about that trauma. Okay. The initial first case is only to understand these are the end points. How we reach the end point, I'm going to show you in the next case. Okay. And the main thing is you have to make sure you come out, and I'll just at 15 now at 15 centimeter. You just watch the monitor again. The patient cooperates. You may be able to see the vocal cords also. Okay. You will be able to see that is what is closing and opening is the arytenoid fold. What you see at this place at 9 o'clock is the left piriform fossa. What you see more towards this here is the right piriform fossa. Now you can see the vocal cord. Can you see what is towards this 3 o'clock is the right vocal cord. There is the left vocal cord, right arytenoid, left arytenoid, right piriform fossa, left piriform fossa. This picture is very, very important. Okay, then come back a little bit. You will be appreciating in front of this epiglottis also. You will be able to appreciate epiglottis, but here he is retching. Let us see next case. Because each case will allow us to understand a part. It's like a piecemeal digestion. So we are going to digest only few facts. In other words, endoscopy can be accomplished if you do the navigation properly. All the parts can be seen, if you know. But main important thing is our posture is very, very important. I didn't do this one. I don't do movement. So your movement should be the table. It's like laparoscopy. It should be waist down table. See, you can see the waist down. Some people will keep it like that. Don't make it difficult. So it should be waist down table. Okay. Left lateral position. Neutral head. Very, very important is his head. You see the pillow. Size of the pillow is very, very shallow. And we can even manage without a pillow if it is a child. Because a child, they have a big head. So they no, don't need. But if for us, it is a small pillow is a must. Okay. And then make sure patient is reassured. Very often it is vocal anesthesia or local anesthesia. We don't give sedation. But because here we are going to discuss a lot, I have given him 2 milligrams we normally give. Because then as soon as we finish the procedure, he can go. But whatever you do, ideally, there are two things we do. I recommend normally. One, keep the patient on nasal cannula with O2. 2 minutes before if you start and oxygenate the patient, patient's tolerance to the endoscopy procedure is better. because otherwise they'll have breath holding, they have a fear as if suffocate. So you always have it, tell them, breathe normally. Second thing is always have a pulse oximeter. Even though you have a vigilant staff nurse, it's always a good habit to have some monitoring. It is accepted. These are the two minimum things I do, especially when you're going to sedate. Okay. And 30 minutes later, he will be able to go, and whatever he wants to drink, he can drink. Then by then we have everything recorded in the monitor here. You saw there. So we are going to record the whole thing in a computer with a software, Ambalsoft software, where we'll get a printout, talk to the patient, relatives, what finding, what to do next, all these things will be done. So that is a part of your examination. So before endoscopy, what we do, during endoscopy, how we do the procedure, after endoscopy, how we counsel. Both, all the parts you have to learn, even though your aim may be more of a technical skill, how to put the scope, a cognitive skill all around when we have to do, when not to do endoscopy. When you do endoscopy, what findings we see, and when we see such finding, what is the next investigation we need to, that as a clinician you need to understand. So I am taking a class to my colleagues. That's the way I see it as a surgeon. So you should give equal importance to the cognitive skill. Okay, so this is an arrangement where we want to balance whole thing. I think I am sure, if not now, you will receive a copy of our book. If you read all those 150 pages or so, every word has been taken a lot of importance and given. So if you read through that, it's fairly easy to comprehend, and reinforced by a couple of our lectures. We don't give a, those days we used to give lectures 8 hours. Now we cut down the lectures to bear. I am going to talk to you only for 2 hours. So make you think, make you see more. That is our plan. I hope you enjoy our stay here. Let's go inside. All of you go and find a place to stay. In sit, I'll come in 2 minutes. AC போட்டுருக்கோமா. Let's change to slides. ராஜா, பயப்படுற மாதிரி ஒண்ணும் இல்லை என்ன, நான் வந்து அப்புறம் சொல்றேன் உனக்கு. Have a seat. There are some more chairs here. If you, one of you. Can you see the slides? Can you hear me talking? My voice audio? Ajaram? Okay. See, these are the 3 different parts you just now saw. Okay, so I'm just going to have an endoscopy, which is thanks to the Olympus Axion endoscopy. You're all here today, and they are going to give you a couple of simulation model, and if time permits, I'll use a small animal model also to show some tactile feedback for you. So this is a control head that I am going to hold, and this part, the insertion section, will go in the patient, and this umbilical cord will attach to the processor. So this is what we are going to learn in the next 1 hour. That is, before endoscopy, what are the rituals I ask you to practice every day? This is not for today alone. It is for the rest of your life. Okay. For example, when we do this procedure, this is a very important picture. You ensure you have enough people, especially these 2 are important. 3 people are necessary. Recording, sometimes with a foot pedal, we can manage recording, but 3 people is a bare minimum. Okay, this nurse assists, and also she can circulate, she can go out and get something, but restraining nurse is very, very important, especially when you're going to do a under local anesthesia.
Okay. And as I said, first important thing before endoscopy is we need to ensure that we do a cockpit drill. That is, endoscopy has to be checked with all these things, which I'm sure I'll explain in the next case. I don't want to have a dry slides now. So all you need to know is something has to be done as far as the equipment is concerned before we start the plane. Otherwise, what will happen at the middle? Suction bottle is full, they will say, or sir, this bottle of water is empty. You don't allow the staff nurse to do anything with the endoscopy, the trolley right in the middle of the procedure. That has to be checked. Then only you have to proceed, because it's a short, sleek procedure where you don't want any problem. It is a seamless endoscopy. That only will give you a professionalism. So that's a very, very important. Cockpit drill is a compulsory one. Next important thing is you teach your staff. Don't take everything. Like, for example, I'm spending so much time back. There are doing something for me. Otherwise, I have to do. Like, for example, they know the right patient is brought in next, who is indicated. The indication they should know. If not me, my colleague Saktivel, I am sure he would have been with you this morning. He'll be spending some time. So you should know when to do, when not to do. More important is when not to do. For example, even today I had a patient who had a severe epigastric pain, a 70-year-old man. And even though he was referred for an endoscopy, I said, we'll do an ECG, then I'll see if necessary, because it may be a inferior MI. And you end up doing endoscopy on the table, something happens, you are in. So that is the order. That is where I'm telling cognitive skill, your clinical acumen. You can do competent too. And another day we had a patient, pulmonologist referred, sir, this patient has been having a recurrent cough. And not even he is not able to sit properly. If he lies down, he will be orthopenic. And as soon as you put the scope, they'll go for respiratory arrest. Some people are like that. Barrel-shaped chest, typical COPD, extreme COPD patients with a respiratory distress. Don't have your first few patients, because there it will make more damage. So cardiorespiratory distress, suspected MI or suspected DU perforation or perforative peritonitis, better you do other investigation than endoscopy later. Endoscopy is never a desperate procedure. It has to be a procedure well planned. I told you, those days are gone where if there is a GA bleeding, immediately we do. Nowadays, we wait for 6 hours. Okay, we optimize the patient. We make sure the clotting screen is normal and keep blood and everything ready, because it is like a volcano erupted once. Okay, but when you do an endoscopy, if it erupts again in a big way, like a variceal bleeding, with the uncontrolled patient's clotting mechanism, you had it. Now we have lots of pharmacotherapy, PPI, high dose you give for ulcer bleeder. If it is a varices, what will you be giving? Terlipressin is a drug of choice. Now we do right. So 1 or 2 milligram of terlipressin we give. It will immediately control the bleeding, most of the conditions. Very rarely, especially whenever they're rich, they are going to bleed. If you make them not rich, they will not bleed again. Okay. And you have a window of opportunity where you prepare the patient, and get a working diagnosis, ultrasound, everything, get a high risk concern, then you do a procedure when your own staff is available. If somebody called me in emergency at 2 a.m., for example, I'm not going to do at that time, because the staffs are new, patient is unfamiliar to me. I'm not going to venture, even if you're experienced. So never venture. Even a foreign body removal, if it is going to be button battery or some short foreign body, it is preferable to remove. All the foreign body has to wait for the next possible morning list. Don't do it at the middle of the night. It can be seemingly a 5 minutes procedure, or it could be very, very sweaty. You will be sweating out for 2 hours also. It's like some appendix, easy appendix, difficult like that. So never underestimate a foreign body. Okay, never underestimate the bleeder. You have to optimize. Okay, that's why I said everything is very, very important. Consent, without consent, don't touch a patient. And before all of you go, you see our consent form. I am not telling that is the ideal form. You need to design your own form, and the form should be accompanied by patient information leaflet. What do you mean by what is an endoscopy? What you are going to experience? And if I don't want an endoscopy, whether there is any alternative, all those things, as if we have explained to the patient, even though, because you don't have enough time. So you put it in everything as a question and answer in the Tamil regional language, give it for the patient to read. After reading that, I'm signing here. That's what he is going to write in the consent form. The consent form may not have. So very, very important. Okay. And of course, the last two are very important. My stars will take care. Nobody will lie down without fasting for minimum 6 hours. Overnight fasting is ideal. And also denture has to be mentioned. Okay. And I told you about the importance of the clock position. Okay. That you will remember now. And this I'm going to discuss in the next case. Anyhow, how I am going to use. See, this is my left hand. Okay. That is the way I am going to hold. If you see this picture, memorize. I'm going to dedicate each finger to a purpose. That I'll better tell you in the next case. Okay. And for example, the control head in a close-up, you can see I am embracing. It looks as if I am just embracing the control head with dedicating 2 fingers. If you carefully watch, there are 2 buttons anteriorly. Okay. That is, the superior button is with the index finger. The inferior button is with the middle finger. That, in my opinion, some people will always interchange, but you dedicate these 2 fingers in the same way. Always index means it is a superior, there is suction is by index, inferior. The other 2 finger, little finger and neighbor, is only to grasp the scope. It is nothing else. And a thumb is a key important fellow. He is going to control the big wheel, okay, and the small wheel. The small wheel for a beginner or for most of us today and tomorrow, it is obsolete. It is no need. Only 1 or 2 milliseconds I may be using, if at all. Without small wheel, we can do an endoscopy. So that is a trick, because my right hand is very, very important for me. Okay, if you want to navigate in any flexible endoscopy, your right hand, that's why it is a dominant hand, has to do a procedure that is called the torquing the scope. Okay, that you should know. Okay, so I told you the wheels can be moved only with the thumb. I've given you 2 pictures just to see the thumb, the interphalangeal joint for the big wheel and the tip of the thumb for the small wheel, but it doesn't matter. It is all more theoretical, but with thumb is the only thing for controlling the wheels, if you know that side. This is most important thing. What this picture is trying to tell, that is the green arrow is anti-clockwise and the orange arrow is a clockwise. Okay, if you turn the thing clockwise, okay, whenever in the patient's mouth, it turns to the right. Clockwise is CR, to the right, anti-clockwise to the left. If you remember that, yeah. Are you ready, ma? Next patient injection போடலாம். Injection போட்டு patient position போட்டு எனக்கு சொல்லு, நான் வந்தேன். You pull a chair, there will be a chair here, make yourself comfortable if it is all. Or chair உள்ள கூட. You come in little. It is just informal chat. We'll have more formal meeting. So in other words, whenever we do a procedure, navigation is not only done by changing the wheel. There are other 2 things. The shaft is also going to help you, and my body adjustment also will help you. So wheel, shaft, body, how I am going to do is going to make things easier. In other words, navigation, that the reason why you are here for next 12 or 14 hours with me, the next today 6 hours or 8 hours tomorrow, is only to learn this trick. I know all other things are theory. All of you are not good enough to learn yourself. So those things you will. So these are all something like another simple things which in our own surgeon's way of vocabulary, I'm trying to tell you so that you will be able to take the skill from me to you, from you to your junior colleagues. Okay. So then we'll be checking certain things. This all I'll tell you later. These are all their theory. I'll just quickly. This is I'll tell you. Okay. Yeah. So how I am going to. This is the last picture before we go to the next case. Then I'll tell you the steps also in this video. Here, if you carefully see how a video endoscopy helps you to see a beautiful image on the monitor, depending upon the type, it is throwing a light from a processor. Okay, here is a picture, and there I am going to show you that. So the light could be a halogen light, or if you are going to have a better model, even a xenon light. Xenon is the best light, be it a laparoscopy or endoscopy. This light through the yellow cable like this, it's thrown into a dark stomach inside, and the reflected image will fall back on through the objective lens back on this surface of your endoscope. There, this image is converted into electrical messages by this CCD. This is a very important concept. That is a chip in the tip concept. Okay. In other words, there are two types of scopes: chip at the head, chip at the tip. Here, the tip is, in other words, the most vital part of your endoscopy, elective endoscopy, is the last 2-3 centimeter. If the patient bites and damages, are we ready? Then it will be damaged. That's why we say. Whereas in laparoscopy, it is the other end you are attaching. That's why we say all this chip at the head, the chip at the tip. Okay. So here, from there, the image is coming all the way to the processor, where the electrical impulses again become an image. So image to electrons, electrons again to photons. Thanks to this technology, now you need not glue to the eyepiece. You see in the monitor, and we see, and the whole world can see. So this is what we are going to do. So we'll stop it here, and then we'll go back to our next patient, and we'll start. We'll learn next. I'll go first. Slowly you come and adjust your place wherever you're standing comfortable. Okay, come.
Okay. Case equipment indication. இது கொடு glove கொடு. So check endoscopy தான் அது. AP is done at 15 centimeter on the patient. காலையில எதுவும் சாப்பிடலாமா? Today and tomorrow they would have had the endoscopy done for some reason already. One advantage of having a good rapport with the patient, because when you are all here, they should be comfortable. So it's not a environment. Okay. So she had a duodenal. So she had a small duodenal lesion, okay, which we destroyed with a APC. Okay, that's a type of monopolar diathermy. Let's see before we go into the technical aspect. So we want to. In other words, endoscopy could be diagnostic, or it could be surveillance, or a therapeutic, or a screening. There are 4 reasons why we do. First case was a surveillance. I did an operation. I want to know how good it was, something, or is there any problem. Here we did a procedure 3 months ago, like a treatment APC. Now I want to know, is there any recurrence, or it's so it's all surveillance. It will come. Otherwise, the diagnosis is already made. We want to know how the prognosis, something like that. So surveillance endoscopy indication. There is no contraindication. Patient is okay. Now same posture, insufflate. So here let's see. There are 2 buttons here. If you carefully see, all of you, you see on hand. So this is about 1.5 to 2 kilo. It's a very lightweight. Most of the scopes are like that. You put it in the first web space like this, and embrace with the 2 fingers. Engage these 2 buttons. Superior for a suction, inferior for insufflation. Actually, inferior has a dual function. Okay, the dual function is when I press it, it will instill water. Okay, if you see, so that it will clean the lens. Like, but when I just place my finger, it will insufflate. So placing and pressing the same, it will give a dual function. One is a insufflation, is by placing my finger, and installation. So it is a very simple but effective mechanism, the mechanism of which you have to clearly understand. That I'll show you later. Okay. Then about the wheels. As I said, big wheel is the important thing. The big wheel, the way to understand is always turn the big wheel towards you. When you turn the big wheel towards you, okay, what happens is you start looking at upwards. Okay. So in other words, big wheel towards you, even though now it looks going downwards, actually the scope is designed this way. Okay, this is the scope. So big wheel, now you learn the big wheel, what happens? It looks upwards. So whenever you bring the big wheel towards you, the big wheel towards you, okay, big wheel towards me, it will take it upwards. That is what you should know. Okay, so J maneuver, looking at the fundus, big wheel completely towards you. Okay, and J shaped stomach, you go there, antrum is not here, it will be, you have to go that way into that. Stomach is like this. So the configuration, otherwise try 3-dimensional anatomy of the stomach. You have to, difficult in the beginning, you may look, but we'll, as you keep on seeing so many pictures, you will understand. The next lecture I'll make you understand. All you need to know is the big wheel is the only fellow that you have to keep on turning at various levels towards me. So I'll just see first. I'm going to now do something here. I'll tell you. You may or may not be able to see by hand, but you will be able to see what's happening. So what I do here, it gives you a result there, which to my liking. And so each patient is different and a degree, but essentially the same procedure I'll be doing. So I place the endoscopy in the oral cavity. I'll ensure the tongue is at 12 o'clock. Okay, tongue is at 12 o'clock. Happy? Soft palate at 6 o'clock. Okay, then push it in a little bit. Push, push, push. Okay, then big wheel towards me. If I do, I'll see another structure coming that is called epiglottis. So epiglottis will be coming in a minute. See, that is epiglottis. See, say hello. You go behind the epiglottis. Okay, then you go and it is a post-cricoid region. You dock at the 9 o'clock, that is in the left piriform fossa. I told you 9 o'clock is the left piriform fossa, and you slide your scope there. That is called a slide. You just, because when you go in the right place, you will not have any resistance. It will just walk in. That feel you have to get it. Never do under force. Okay, now always scope 2 fingers like this. So keep on insufflating when you are in the esophagus. Okay, keep reading. If she is good, 20. So 25 is normally sometimes you will get. So here this is the anterior wall, this is posterior wall. Posterior wall, how do you know? Thin patient's spinal column, vertebral column you will see. But here it is posterior wall, anterior wall. But at 30 centimeter, if you carefully see here in the monitor, you can see pulsation. Can you see? So that is more or less constant. See, that is the. So whenever you have a fish bone at 30 centimeter here at 12 o'clock, you should be very careful. A impacted fish bone, there is, when you take it out, it may, because the pulsatile heart, it will keep on bleeding. That's why whenever you have a fish bone 30 cm mid-esophagus, if somebody says, did you do a CT scan? I'll ask them, because you don't know how much is penetrated. The depth of penetration you have to see. It may be, okay, very, very important. Then you keep going, then you see the Z line. Can you see the Z line now, the transition? And also at 9 o'clock, there's a small island of mucosa. Can you see island separately? So this is not abnormal. Sometimes it will not be clear. So you just go in, insufflate, you enter into a like a big cave. Stomach is like a cave. You enter, the first time you enter, you always enter the body of the stomach. You don't enter the fundus body like that. Fundus is seen on the way out. That's the next important thing. Okay. So I enter. Now, if you watch carefully, there is actually a small polyp. I don't know how many of you noticed, but now she is retching. Now, as you go in, now this is the anterior wall, posterior wall. This is the greater curvature, lesser curvature, I'll say. And you can see a small polyp. Can you see there? At 6 o'clock, see another polyp in front of it also. See, small polyp. This is a sessile, about 2 millimeter polyps. Okay. So I have to walk along that polyp. Imagine the polyp is the greater curvature. Let me just. See, can you see the anterior wall? So you walk along. How I do? This is very 3 important movements I'll do to walk along the greater curvature. I push the scope about 5 centimeters at a time. Big wheel I just slowly towards me and torque the scope to the right. Okay. Push 5 centimeter, big wheel towards me, torque. 5 centimeter, big wheel towards me, torque. If I do keep doing, then I'll be coming very close to the pylorus. Okay. So his pylorus will be there. And the pylorus, ideal pylorus, now it is more towards 12. It should be right here. But not everybody will be cooperative. This patient now, so far, she has been cooperative. Now she is feeling restless, maybe because of. So I'll just go a little bit in. So I'll bring. Now it is more or less a good pylorus. Now you can see right in the middle of the monitor. When it is in the middle of the monitor, pylorus at the center of the monitor, scope is straight, then you can just walk in. Okay. In other words, you are permitted to enter. Now you enter the first part. The first part to second part is very complex because it needs 3 things to be done. One is the wheel, then body and soft. So I'll just turn the wheel alone. Big wheel towards me, small wheel away from me, and I am also more towards the. I'll start showing the patient, my back to the patient, something like this. Okay. You can see a lesion there. The small sessile polyp, actually much smaller than before. Okay, this was seen and turned out to be benign lesions. That's why we left it. Okay, it looks much smaller, but we can always destroy at a later date. Okay, APC or something. Let me just come back a little bit. Yeah. If you see here, 1 o'clock, this is the thing. So if you see here, this is actually the ampulla vata. I'm just trying to see. This is not the ideal one, but if you see all the folds in the D1, D2 are more like a circular folds. But this is the only vertical fold. You will be able to appreciate even a bile trickling down. This is not the ideal papilla for you to see. Because this being an end viewing scope, this is the best you can see. The end point of your upper GI endoscopy is reaching at least up to the ampulla vata. Okay, and the ampulla vata is almost always seen as a vertical fold on the 9 o'clock position here, and just opposite it, and you will be able to see about 1 centimeter flat lesion with a central ulceration. Okay, and it could be something like a duodenal neuroendocrine tumor, small endocrine or carcinoid, but definitely doesn't look too nasty to me. We have done already biopsy. I'm interested more of navigation only. I'll just come back. Now you watch. Now I am back in the pylorus. Okay. In the pylorus, we have seen the greater curvature. We have seen the pylorus. We have some extent seen the D1 and D2. What I haven't shown you is a very equally important thing. That is a lesser curve, especially the incisura. Incisura is the most important thing because the commonest site of benign gastric ulcer in the antrum. To see that, you come back and dock the scope more or less in the antrum, antral docking, that is called. Okay, and then big wheel slightly towards you. Okay, if you do that, you will be patient will be not retching. You'll be able to see like a small ridge going from this. You have to distinguish from the peristalsis. See, you can see. Let me. Yeah, that is the ridge. So can you see this ridge? That sometimes that is the incisura. The incisura is usually stretches around 7-8 o'clock till around 2 o'clock like that. Okay, you have to constantly like that. See, can you see now? Now it's better see. So below which is the antrum, above which is the body and fundus. Now you are able to see here. Okay, this part is called the incisura. This is all in the lesser curvature. See, this is the greater curvature. Okay, from here it is lesser curvature. You have to imagine. So 12 o'clock to. So I'm going to now big wheel. See, watch me. I'm completely turned. I can't turn anymore. We can't turn anymore. If we do that, then I'll start seeing my scope and also the rest of the stomach with a fundus puddle of fluid. I'll pull the scope, turn the scope anti-clockwise. Okay, anti-clockwise, pull the scope, and you see in the monitor carefully, the scope is nicely gripped by the cardia. Okay, there is no gap. So in other words, it is nice competent. In other words, there is no hiatus hernia. There is no laxity of the LES. Lower esophageal sphincter is good. Okay, so C knee knot should not have any reflux disease. There is a little bit of inflammation there. That is different. But this is a cardia. Because if you have a tumor there, you should. And here the confusion will come, which is lesser curve, which is a greater curve. Okay, the portion of the stomach which is close to the scope is lesser curve. This is lesser curve. This is the greater curve. Okay, so if you have an ulcer here, for example, commonest site of ulcer, high up in the lesser curve, you have to tell, and about 2 centimeters from the cardia. Like that, you have to measure. If there is an ulcer here, you have to say it is along the greater curve in the fundus. Like that, you have to write. So you have to make a diagram, and you can see some shadow here. That is actually the bluish shadow is because of the spleen, and you can see because cardiac pulsation is seen the inferior. So cardiac pulsation, splenic bluish discoloration, puddle of fluid, where you see all the coins, anything in the stomach will be lying here. That's why always gastric foreign bodies are more challenging to remove because they will be in the fundus. They'll be always in a puddle of fluid. Unless you are careful, it's very difficult. Okay, fishing underneath the water. Okay, now why she is making noise? Because distended stomach. Okay, I'll just deflate. Okay, biopsy gudma. See, if you carefully see the lesion we saw in the duodenum, and the lesion now you are seeing here are more or less similar. Okay, and if you have a like a high definition, better, I mean, this is again reasonably a good definition scope, 150 series, like a 190 or thing, you will be able to get the surface capillary patterns much more magnified, much more clear. Then you will be able to make a diagnosis even during endoscopy. If necessary, we can always do a biopsy. Okay, and you see the next important lesson you will learn today is the trajectory of your access channel. Where whatever you insert, it always come at 7 o'clock in Olympuscope. Okay, it is your job and your staff's job to see which. So you have to see like that open. So I have to see. So I am able to get to that area that is close. So this may look very easy. The targeting is very important because everybody has to starting. Has to hold it until I take it and put in a bottle. I have to keep watching it. It's not bleeding unduly. I may have to go one more time. Okay, and I have to ensure beforehand whether the patient is on antiplatelet drugs. That's why the history is important. Okay, at this time we can't ask that question. So that's why open. So sometimes if it is a small polyp, smaller than that, even by doing this, we will remove the polyp. Okay, in the colon, anything less than 5, open mama. This is called a cold biopsy. In other words, biopsy can be taken by applying a diathermy and taking. That is called hot biopsy. Cold biopsy is you just take it. It will bleed, but thanks to her hemostasis, it will eventually stop. Okay, if at all you just irrigate that area like that, you will see already it stopped. Just there is no constant. You get, if you want, you can put some water and see. It will slowly will stop. This amount of bleeding will 100% will stop. We'll look at the histology and see. If necessary, we can put see this and this. All lesions start appearing. Whether they are metaplastic polyp or it's a neuroendocrine tumor or it is just a simple hyperplastic lesion, we'll find out, but doesn't look anything serious. Don't worry about that. Our aim is to navigation. Okay. And another test we may do is of H. pylori. Okay, Helicobacter pylori. For that, what we do is we usually take a little bit from the antrum of the stomach. Okay. So we'll so what you do is you watch her hand now. So this is important. Okay, you watch her hand and see what I am doing. I'm not going to take a biopsy now. Open, close, open, close. So what you understand here is she is just following my command like a military. Very, very important. And open is separating finger. Close is approximating the finger. So this is a universal handle. This is all endoscopy will have same handle. Because you have to teach you, otherwise they'll do open means they'll close it. Because if the same mistake they do within the channel will get damaged. So you have to reverse. So both are in the same frequency, a harmony with close. Now, so once she knows my taking, what I'll do is I'll take it inside the endoscopy like this. Okay. Then I go where exactly I want to take a biopsy. And then I know exactly it's going to come at 7 o'clock. Open, close, antrum or pre-pyloric region I can take. Say this is called go and pinch it. Okay, then lift it. You lift the whole mucosa only can be lifted. The muscle is not coming only. Then snap it. Okay. Now he sees in the closed position. She has to keep it closed. You can see. Then as I'm taking it out, I'll keep watching is there any undue bleeding. Then open and see it. And there is a small in the cusp. So if you carefully see, there is a small, this is called a spike forceps. There are two types of biopsy forceps. With the spike, okay, without spike, like a Nangura. So because whenever you have a fibrous tissue, always we have a spike forceps. Okay. So we have taken that and I'll just come out here. I think we have enough time. And again, we'll just see if you see here also there is a Barrett's patch. Let us see if there's any other Barrett's patch. There is no other Barrett. See, next important thing, when you withdraw the scope, one of the important technique is patient, if you allow, they'll vomit the scope. Then you lose seeing about 5. So I kiss the patient's mouth like this. I take the scope like this, 1 centimeter or 1 like that, like slowly. This is the rather than doing this way, I am doing this way. You see, this is another important trick you should know. In other words, whenever you are withdrawing the scope in the esophagus, it's always like 25, 24, not 20, 15, 20 like that. You should not like that. Withdrawal is as important as insertion, because sometimes you are more preoccupied trying to reach D2. You will be seeing more pathology on your way out. Only way is by gradually pulling out, and whenever your hand is there, she has to relax. Whenever my hand is busy here, she has to hold it like a cigar grip. So your staff nurse here, she should be in harmony with you. And the staff nurse doing a biopsy should understand. So you have to have a teamwork. Otherwise, there is no point in having, because this, as you can see, the patient is making all sorts of noise sometimes very violent. You have to do it, because flexible endoscopy, one of the attraction is it is a very simple procedure and a luminal procedure with patient can walk back. So there are a lot of advantages. At the same time, it is actually, for you, it is a little stressful, whether you like it, at least in the beginning. To make it easy, you have to make sure you prepare your environment to such an extent that it is not only you, you have your team also. Like actually today, I don't know, some of you have your staffs ready. I'll give a number. They are doing beaming from GVN Hospital, a technician's course from 1:30 today till 4 o'clock, incidentally. I'm going to show you just a glimpse of that while you're having your lunch also. But just to tell you the importance of them also could be equally taught. Okay, so let's go back there quickly. Rajana, what's the time now?
Yes. Okay. So let's go on non-stop next 10 minutes. Okay. Then we'll be more relaxed. Because we are doing. Okay. So I told the role play. This particular picture will clearly explain what's the each staff. I think you've already witnessed what everybody is trying to do. The mouth holding staff nurse, in addition, what she is going to do. She will be constantly telling 1 or 2 words to the patient to reassure. Number 2, the restraining nurse. She will be also looking at the pulse oximeter, make sure the patient is comfortable. And assistant, she did a biopsy once and H. pylori test. She helped me in 2 occasions. 4th, of course, we have our luxury of our recording system. Okay. And this is a close-up view of how one has to. The first picture here, you can see the pillow should be very shallow, head in the neutral position, and a victory sign grip with a hand on the back of our occiput in order to avoid. Don't keep it big pillow, and even without a pillow also very cumbersome for the patient. So you have to decide upon the patient's head circumferences will decide. Okay. And these 2 are very seldom done in very many institutes, I know, but I recommend it mainly to ensure the safety of the patient, and also patient tolerates better when you oxygenate the patient. So you have a not necessarily a central O2, you can have a mobile O2 also. That is up to you. That is it is one of the standard of care in abroad. Okay. Now I am going to tell you the steps in what I call 6 steps of rule of 3. In other words, I am going to stop at 6 different stations. I reach there only by seeing three important anatomical details or three adjustments. Let me see. When I put the scope in the oral cavity, these three things you always try to recognize. You always, first picture you see in the monitor is always an upside down view. Always like a, so tongue above, because you are placing the endoscopy over the tongue. But when the monitor, it will say, look opposite, because it is going this way. I already told you, when you are holding the scope, it is okay. But when you are holding like this with a shaft in the other hand, it looks opposite. Okay. It is, in other words, your inverse image is a normal. Don't try to reverse it back. Don't try to bring the tongue below, then it will be difficult for you. So leave the tongue at 12, leave the soft palate uvula at 6 o'clock, proceed in the little gap in between them, gently with a big wheel towards you, gentle, okay, to say hello to the epiglottis. Once you see the epiglottis, you are nearly there, because all you have to do is go behind the epiglottis. Because what is in front of the epiglottis here is a vallicula. You will be hitting. Okay. So you sometimes tumor may be there. That is posterior 1/3 of the tongue is joining with the epiglottis with the place called vallicula. There also sometimes patient have lesion, but you have to go somewhere here. So when you go there, you will be docking here. Actually, you will be seeing this perfect view, but it is all dynamic picture. Nothing is static in endoscopy. It's like, so you have to imagine. So if you understand this way, then it will be easy. Sometimes I can spend about 2 minutes in a patient. Other patient even will not allow me even 1 second. So I have to rush in. So whenever you have time, you understand vocal cord, right side vocal cord, right arytenoid fold, right piriform fossa, all to the 3 o'clock. 9 o'clock is the left side. My job is to keep the tip of the scopes more like behind here in the left piriform fossa or right in the post-cricoid region. This is post-cricoid region. Okay. In other words, this is the post-cricoid region is like a dumbbell, like this it will be. This is, imagine, this is my left piriform fossa, this is right piriform. Post-cricoid region is very, very shallow like that. So you go through the hole, which is you are comfortable with. So you place the scope in the left piriform fossa. Some people instill water, inferior button, press it, it will instill do. Patient swallowing reflex, patient will swallow, but there is no need. My recommendation, don't instill water, because if you instill water a little more than what is your liking, the water will go into the larynx, patient will start coughing. So I won't recommend, but that is one of the technique people will follow. Okay. Next important thing is, once see, this is what you dock at 15 centimeter and sneak down or slide down the cricopharynx as a patient swallows. But don't push it when the patient is coughing. When the patient is coughing, cricopharynx is closed and vocal cord is open. In other words, like windpipe is open. You will go into the wrong passage. You will see a triangular configuration tube, which is bifurcating, trifurcating every 5 centimeter. Because up to 40 centimeter, you should have only one lumen. If you have multiple lumen, patient is blue, that means it is a child's diagnosis. You are in the wrong place. Accidental bronchoscopy. You immediately take it out, wait for about a couple of minutes. Okay. So you have to recognize that eventuality. Okay. So this view is avoided. Then I told you in the esophagus, nothing much to do. Insufflate, enjoy the view at 15, that is where you enter. 25, if there are any restrictions, or around 30, if at all some cardiac pulsation, but 40, you just have a pause, because there the Z line has to be appreciated. Okay. As I said, we'll have, I think one patient, maybe very elderly lady, a thin patient, a aortic arch with aneurysm, or a prominent left main bronchus will appear at anteriorly. Okay, like this, but not always. Why this is important means, foreign body by nature, if they are a big foreign body, if they cross the cricopharynx, they usually tend to stay more or less at this level. That's why we are interested, not because of the anatomical things, because we don't recognize this anatomy, but most of the foreign body will be below the cricopharynx, more or less like an aortic arch or cardiac, that is left atrium level. And especially if they are a penetrating foreign body, penetrating anterior wall, that is 12 o'clock, you should be very, very careful before you disimpact. Okay. And the two important quality of the esophagus, all of you understand. Esophagus, 6 hours fasting means it has to be Like a pin drop silent, it should be without any water. Not even a drop of fluid should be there in the esophagus. If there are 10 ml of fluid or 20 ml of fluid, is achalasia or obstruction. Take it from me. Okay, you have to suspect high index of suspicion when there is a fluid or food in the esophagus. Because peristalsis for you, it may be difficult to recognize. So I would recommend you, it should be empty. If it is empty, pathology is unlikely. Then you go there. Z line is never drawn like a pencil. It could be round like this, or it could be sometimes star shaped like this, or it could be some mucosal islands like this. It can be of any shapes. Don't overdiagnose Barrett's. Don't overdiagnose esophagitis. That is a common mistakes people do, but we'll make sure that is not happening by our subsequent class. But what I'm telling is, Z line is never a line. It is a wavy, like a star. It could be up, but usually it is around 38 to 40. Okay. And another thing you will recognize in the next case is, Z line is what you see inside with endoscopy. What you need to see is a hiatus outside also. In other words, if your esophagus is actually gripped by the right crust, hiatus, okay, that is giving you an extrinsic compression. That extrinsic compression, you can see if the patient is coughing or patient says ah like that, if the patient, they'll go for a pinching mechanism. In other words, the pinch cock mechanism of diaphragmatic right crust, you can appreciate if you ask a patient, in the conscious sedation patient or a patient at a local anesthesia, you will be able to tell, ask a patient, I'll ask the next, that will be just below the Z line. So in other words, Z line at 39 centimeter, hiatus at 40 centimeter is usual norm, most of them. In other words, the distance between them is hardly a centimeter. If it is more than 2 centimeter, you suspect hiatus hernia. For a beginner, when to suspect hiatus hernia, there are 3 things. 1, if you go in, it is wide open patulous hiatus. In other words, it is not we are trying to open it. It is already wide open. Okay, patulous hiatus. Second thing, you see the Z line well above. It is not 30, it is well above. Okay, the distance between the hiatus, real hiatus, where the pinch cock and the Z line is more than 2 centimeter. And third, when you do a J maneuver, the scope is not nicely gripped. If you look up like that, okay, and there is a gap. There is a gap between the scope and the cardia. That if you see a case will be easy to understand. See, if any of them are present, then you can suspect it is a lax LES or a hiatus hernia. Then we enter the stomach. I told you, we enter only here. We don't see the fundus. We go straight into the body. And we along the greater curve only we walk. We go, then go upwards. See, the scope is going upwards now. So because it's always traveling up and up all the time, the big wheel is always towards you, depending upon the shape of this. And also the patient turning, the stomach is actually turns to the right. So you have to go up to the right, upwards and to the right. That is the secret of stomach navigation. Upwards means big wheel towards you. To the right means clockwise. And push, you have to go, because you have to, for about 15 centimeters is the distance. That's why 5 centimeter, 3 aliquots, I say. So if you, and also this navigation, I told you, you have to imagine anterior wall, posterior wall, 6 o'clock is the greater curvature, 12. So if you navigate along the long route like this, okay, enter along the long route, exit along the short route. That is a secret of examining a stomach. And how we enter and reach the pylorus, these 3 movements you do. Rule of 3 again, the 4th rule of 3. That is big wheel towards me, clockwise, then push the scope. 3 times you keep doing, or sometimes 3.5 times, I will say. Then you will enter and have a view like this. You bring the pylorus bang at the middle of your monitor. As you go closer and closer, the pylorus will get bigger and bigger like this. Okay, it's like as if you are just outside this side of the room and you're looking inside the room. So in other words, the D1 can be better examined by stationing yourself just on this side of the pylorus. Because D1 is, after all, is a small place. Okay, you can't go and manipulate too much of manipulation. It is only go. You can't turn right, left that much. So always we want to, for example, if I want to do an injection of an anterior duodenal ulcer, I'll station myself in the antrum. I'll take the needle across the pylorus, go and inject, because anterior wall is at 9 o'clock again. Posterior wall is at 3 o'clock. That is another rule of anatomical understanding. Okay. So pylorus at the center, then it is easy to enter. This is the easy pylorus. This is a difficult pylorus because it is a down facing. This is side facing. This is all. So if you have a pylorus like that, you try to bring it at the center. Okay. And also the scope, if you keep on turning, you don't know what happened to the tip of the scope. Another thing is you will have the scope like this. You can't push the scope like this. You have to keep end on view. So scope is okay, end on view, end facing pylorus. Like this only you have to enter. That is one important thing you will sometimes will get in the beginner's problem. Then D1, D2 are different anatomical configuration. You will know easily. This is a smooth D1, that is a bulbar part, and post-bulbar region here. Then you enter the duodenum 2, ampulla at 9 o'clock. It is a different. How we reach from here to there, you have to see an important anatomy that is called a superior duodenal angle. What do you mean by superior duodenal angle? Before that, I told you already, anterior wall, posterior wall of the duodenum. So you have to keep going along the long pylorus entered, and when the first part of the duodenum takes a direction change, descending duodenum or D2, there is a portion here. See this portion. This is called the superior duodenal angle. The angle where the D1 becomes D2. You have to push the scope up to here. The commonest mistake done by the beginner, one more, is they do all this movement, but they are doing it in a wrong place. In other words, they're changing, like Michael Schumacher, if he's turning the wheel, for example, if you turn the wheel in the right place, he'll go to the extreme of that lane, then only he'll turn. He'll not accumulate somewhere. So like that, you have to go to the extreme here to that area. Don't make a, see, for example, if I do what I am going to say next slide, here it will not happen. You have to go further a centimeter, see the superior duodenal angle. Now you do what I say here. That is big wheel again towards you, small wheel away from me, and I turn this is the most important thing. Myself, I have to turn my body, okay, to the right to face the monitor. I was facing the patient, talking to the patient. Slowly, I'll turn myself. That is, you corkscrew yourself. You have to imagine you are turning right. You turn, like any corkscrew movement, okay, it will drive you down. So very simple problem. So you will go this way. Then you will descend. And what you do now, once you are well in, you start pulling the scope now. If you start pulling the scope, this part actually will dive further in. That is called a paradoxical movement. As you pull the scope, now the scope, rather than lying on the greater curve, it will start hugging the lesser curve now. Because it will be, you can see the lie will be this way. I'll tell you the picture. This will be like this. It was like this, okay? And it will be like this next. So this is what happening. And for that only I'm telling. So big wheel towards, or you can see it's small wheel turning. If you're not comfortable, torque the scope to the right, and I'll turn my body and I start pulling 60 centimeter. Up to that, you have to pull. Here I'm going to show you all those. As I said, everything in a one case is very difficult to comprehend. Then I docked in the antrum. In the antrum, I big wheel again, and I'll see the incisura. And this is called a J maneuver. I'm able to see the cardia fundus like this. I'm able to completely retro. This is called a retroflexion. And I keep pulling the scope this way. Then the scope will go shorter and shorter, and you'll be able to look like this. So this is the hockey stick endoscopy. This is what I am going to do to look very close-up view of the cardia. So this is what I have done it. Then distensibility. The rugal folds will appear, disappear. That is what you need to see. And you have to prepare always, abandon the procedure if the patient is uncomfortable or if the parameters are not saying that patient has a pulse saturation, immediately withdraw the scope. The least thing important is discontinue the procedure. That's very, very important thing. Okay, whenever you suspect cardiorespiratory distress, patient is apneic, what to do? Don't keep the scope. Take the scope. Then only patient can breathe. As simple as distance, aspirate the stomach, take it out, ask the patient supine, you just keep a pressure, shout at him on the airway. Sometimes if you give too much of sedation, panic button, they suddenly go for a breath holding. So you just give a big tap, they wake up. So you should not get panic very easily. Luckily we have our emergency room nearby. We have the crash trolley, everything. Okay, whatever you do, you should not have any mortality on the endoscopy table. Even for a OT table, we know. So that, okay, let's go to the there to see the next case. Then we'll have more relaxed because the transmission is going to be over. Just let me go in.
You on? Can you hear me? This is the final case for transmission. Okay. This case may have a pathology. This patient has a dysphagia. Whenever patient has a dyspepsia, that is the indication, diagnostic, easily you can do. Dysphagia for a beginning, it's like a acute cholecystitis. First lab chole, you will be hesitate to do something like that. So one thing I need is a guide wire, a flexi tip guide wire. Next thing I need is a biopsy force. I tell you why. And you can see her, she is very emaciated look. So I won't be surprised if she has a malignant process or some process in the esophagus, because dysphagia never functional. It is always some pathology. Most likely cause is going to be something mitotic. Okay, so you have to prepare for that. So because in the middle you should not rush. See, she is rushing now. So I know what is. So we need to keep everything ready. So flexi tip guide wire is a bare minimum. I'm not intending to do any dilatation because being a procedure. Okay, I will make procedure as simple as. Okay. So tongue above, short palate below, epiglottis. Sorry, you are able to see the short palate. You are able to see the uvula and also epiglottis here. See, in front of the epiglottis is vallicula. We are not interested. You just go behind and see the vocal cords also, if possible. See vocal cords, nicely seen. There is no tumor in the pyriform fossa. Okay, left pyriform fossa, right pyriform fossa. I am putting in the left pyriform fossa, slide little bit and then. Okay, let us see. Nothing. Okay, so it's more of a reflex disease. So what I've done, I've gone beyond the cricopharynx. I entered the esophagus. Okay. If you have any difficulty, flexi-tip guide wire. See, for example, imagine there was a stricture in the esophagus. You don't know whether you want to go or just whether you will perforate. Always a fear of all of you in the beginning is perforation. Okay, for example, because he is appropriate lady, let me just come back a little bit here. Sometimes you have one of the conditions that will behave like this obstruction muscle is Plummer-Vinson syndrome with a post-cricoid web. Okay, in that case, what you normally do is you just take a flexi tip guide wire like this. Okay, this, can you see a guide wire coming at? Can you see? You just push it easily when it goes. Okay, you just put it about 10-15 centimeter, then thread the scope over that like that. Okay, then you take it out. In other words, it is like what the anesthesiologist will normally do. Okay, in difficult intubation, they put a bougie over that. They did same principle. You have a flex. So whenever you have a anemic patient, foreign body sensation, tablet not able to swallow, you go intubation is going to be utter failure. So you have to mentally prepare. This is going to be a challenging intubation. You keep that flexi tip, it will slide, it will open and open. You will see a post-cricoid web, small hole will be there. Through that, you pass this guide wire, wire will go easily. then you pass this endoscopy. I'm sure as a surgeon, it will be fairly straightforward procedure. There is little bleeding, don't worry about that, it'll all stop. Okay. Then you enter. So now around 30 centimeter, you can see the pulsation, cardiac pulsation. So this is the posterior wall of the esophagus, anterior wall of the esophagus. We are crossing around 30 centimeter here, and around 40 centimeter is this is the patellus hiatus, isn't it? The hiatus is reasonably lax. I won't say it tight. Then you, as you enter, you are entering the body of the stomach. As you enter, I see what I'm doing. See, I'm doing a clockwise torque, big wheel towards me, walk along the greater curvature, push, push, and push. You will get to the pylorus. Okay, and if you bring the pylorus little closer, sometimes minor adjustments you have to see, but mostly if you get in the center, there is nothing much. What you see in front of you like this, here more toward this is the anterior wall. Okay, if you want to see the posterior wall of the duodenum, sometimes what I have to do is I withdraw the scope to some extent like this. See, withdraw the scope. Okay, and see, watch me. I am doing. I turn my body like this. Okay, and then small wheel, turn it more towards me like this, and then pull the scope. And I'll see more of this side. In other words, whenever I turn this side, I'll see this side better of the wall. If I turn this side, I'll see this side. So posterior wall is seen like this. For example, if you turn, my body movement is making some movements there. Can you see? So that adjustment you have to do. So body movement is very, very important in the duodenum, because in duodenum, the space is very little. Subtle movements, for that your body is more reliable than the wheel. So, but once you enter, for example, here, I'm entering here, I turn my body. See what I'm, the whole scope is actually 1 meter scope. Okay, I pull the scope and you see the monitor. Actually, I'm going inside. I'm going deeper. See, I'm going deeper actually. That is called, paradoxically, I'm going deeper. Till what level? I'll be going up to 60 centimeter. What is the level now? Now this is the shortest route, and ideally the ampulla should be somewhere at 9 o'clock. Okay, somewhere here it will be there. Somewhere it will be hidden, but don't look for it. But because as soon as I change my position like this, I'll fall back again. So every time you enter, I'll enter again one more time for you. Pylorus, I enter. Once I enter, then whenever you see most of the beginners, what you picture you will get is what we call this picture. That is called the insufflation is inadequate, and also you are touching the mucosa, you'll have a red out. So whenever you see a red out, you come back like that. In the monitor, you come back. This is, we are not touching now. Now turn my body. Okay, big wheel towards me, small wheel, then pull the scope. See how I am pulling. See, I am not pulling with my hand. I am pulling by this way. So this is one simple mechanism. You can see paradoxically, it is diving inside. See, it is diving inside. As soon as I turn my body like this, it will slowly fall back. So if you want to stay in D2, do a cannulation of you have to show your back to the patient, something like that. That is the only way you can stay for however length time you want. And this is a typical incisor. Now big wheel towards me. This is antrum below, body and fundus above. Okay, and see other lax hiatus. Can you see? Now you can see I can put another scope in between. So that's why she may have a reflex and some foreign body sensation. So it is a false alarm, but no mind, because she was so emaciated. I was thinking we have to look at her chest X-ray also to see whether there is any other cause for the weight loss. She has small linear. So if you carefully see, there are lots of signs to say she has some ulceration. So I'm going to do a H. pylori test. Okay, so you can see it is a gastritis. There is nothing to suggest more serious sinister problem like linitis or anything. Okay, they're all, if we see along the rugal folds from the wrist, this is called erythematous gastritis, predominantly over the rugal folds. So if you see the rugal folds, Wherever there is a rugae, they are all okay, and it is mainly where the fundus is normal. This is the splenic side, that area. So here there is some inflammation, body. This is called the inflammation will be whole stomach. That is called pangastritis. Inflammation in the distal stomach. There is distal or antral gastritis. Inflammation may be only proximal. That is a proximal or fundic gastritis. Only body. There is corporal gastritis. So there are a lot of terminologies we use. But the medical gastroenterologists will be very fond of is type A and type B gastritis. They will put to make you sweat. So nothing. Type B is H. pylori gastritis. That is called, I have bottom half gastritis for me to understand. Type B means bottom half of it. It's always antral. Whereas type A is a proximal. That is a parietal cell, like a B12 deficiency, pernicious anemia, and then have a type A gastritis. So here we'll see whether what type of gastritis, whatever. Open. In my last case, positive. Close. Sorry. Here, not H. pylori.
From antrum, sir.
I have taken it not from antrum, from the body, because antrum also near normal. Not, if you see antrum, we could have taken, ideally we should take antrum, but I have taken it from body.
So you have to do blood test or HP, sir? This one.
Both we can do if you're interested, but I am not interested in a biopsy, but I am more interested to exclude H. pylori. That's why I have taken where it is inflamed. Now deflate and will come out. So what we have learned in the last 1 hour 15 minutes by seeing 3 patients, or I'll come to that. We know that how to get the checklist of all our equipments and to get the right patient for a right indication with the right monitoring device and with the safety of the patient as a priority. If you do that, then do the procedure. Our aim for the next and the last an hour or so is how to comfortably navigate. Now I'm sure you will have a reasonable idea. What idea you should have is, it looks as if I can do it. I'm not explaining you. So at least that confidence is the first stage of your right direction. Next 3 cases, I want to do it. Okay, I can do it is the first thing. Then I want to do it. Then you will be doing it tomorrow. Then I am going to do it rest of my life. Then you will be start teaching it. So that is the progress in a ladder. Like you are observing, then you assist in parts, then you do independently, then you start teaching. So the ladders of endoscopic training is there, and we are climbing in the right direction. Now coming to the H. pylori kit, this is a commercially available kit, okay, RUT test, where you put it with a small drop of saline. The yellow disc, if it changes to pink color in 30 seconds to 1 minute, rapid urease test, RUT means that is positive, okay, and it hasn't turned, so it is negative last case. We'll see this case also, okay. So on behalf of Lotus Hospital, we are signing off from our YouTube channel. We'll go back and continue our discussion. We are not going to signing off. It's only there. Okay, Rajanam. Okay, thank you.